Hello, I'm pleased to be with you and grateful for this opportunity to address you about some of the aspects of personalized medicine as they relate to the developing world and the technologies that we have. So our objectives today are to examine how this interface technologically of digital pathology and artificial intelligence may interact with some of the demographic changes we're seeing in the world, and particularly in light of the recent pandemic, how those technologies can interact to make a difference. And hopefully that process will motivate you to join me to save the world. I have nothing to disclose. So let's start out with a big number, 21.7 million. That's the estimated number of new cancer cases worldwide in 2030. That represents a very sizable increase over the actual incidence measured in 2015, and prompts us to ask why, and my word, what are we going to do about it? Related to that is this question, which I think haunts me at night, and I hope disquiets many other people, because this is a big problem. How many of those 21 million people will get an accurate diagnosis that will allow them to gain access to modern treatments? Well, very simply, not enough, certainly not all. And so with that disquieting news, let's say, what next? What do we do now? Well, what's really going on here is that the number of communicable diseases has been in a rather gradual decline for the last several decades, while the non-communicable diseases, cancer, ischemic heart disease, and stroke, have been increasing worldwide. Now, this would probably still be manageable were it not for the fact that most of these demographic changes, most of the changes of declines and increases, are falling upon the relatively less developed portion of the world. For example, and you can see what a problem this presents if we break this down and look a little bit more closely. So let's just take the number of pathologists currently practicing in Africa. Well, believe it or not, it's probably somewhere between 1,000 and 2,000 practicing pathologists. On the other hand, if you look at Africa's population, 1.3 billion, 1.4 billion, that's an enormous burden on this number of pathologists that cannot possibly be met. And if we look at projected increase in the number of cancer cases over the next decade, they're going to be facing millions of additional new cases. And even with encouraging progress with training and building systems and so forth, this number of pathologists is very easily going to be overwhelmed by this. Similarly, in Southeast Asia, maybe a little bit brighter, a slightly higher number and lower population, but still a very sizable increase. And of course, this is quite widely distributed over the areas, with places like Singapore quite well staffed, Thailand maybe okay, but Cambodia, Laos, Myanmar, some of these other countries in more serious difficulties when it comes to pathology manpower to meet this increasing cancer burden. So that's where disruptive innovation comes in, because this is a large population of people who are essentially underserved. So let's just do a quick review of what disruptive innovation is. It began with my good friend Clayton Christensen, who began asking this very troubling question in 1990: why do great firms fail when there are great technologies and those sorts of things? Why do these firms fail? Well, he developed, in the process of doing his graduate thesis, the theory of disruptive innovation. And essentially, there are several points in this, and we can begin to analogize this or analyze this as it pertains to healthcare. But essentially, existing companies follow this development curve here in blue. They have a set of customers, they develop new products, they service those customers, and they continue to move up, both in terms of quality and technology, and usually price, striving to satisfy the needs of their customers. But what eventually happens is that they begin to exceed the needs of many customers, or there are many customers down here that they were never even serving. These gaps, these might be likened to the Mayo Clinics or the Roches of the current world that are developing products, meeting a need for high-end, sophisticated services to a defined population that is very loyal to them, and they derive great economic benefit from that. But that leaves a tremendous number of people underserved and a tremendous market opportunity. So the disruptors enter, and they're not meeting the same quality standard to begin with. They're just giving you something that's okay, but better than nothing. And as they continue to improve, to strive to meet more of their customers' demands, they begin to again approach that customer need level where they can serve a larger number of customers, and that eventually disrupts the incumbents. Now, how does this apply to healthcare? Well, what does this tell us about our kind of scenario with regard to the developing world? Well, first of all, the competition here is not between the Mayo Clinic and Dr. Mafafi in Rwanda. These disruptive innovations are competing against non-consumption. In other words, people who are not using healthcare, not using pathology services. Disruptive innovations will provide good enough products to those who would otherwise not have access or choose to use a good or service. So the people who are wandering around the country, whose specimens would be tossed in the garbage, or who wouldn't even make it into a healthcare system, those are the patients who would benefit from something that was better than nothing. The other thing that is very, very important and that draws out of one of Dr. Christensen's later works called the prosperity paradox is that innovations in unserved markets can succeed best when they pull in the resources rather than when some International Monetary Fund largesse or some other charitable donation drops in high technology or new innovations. The other very important thing to understand is that established providers will ignore unserved markets and focus on established customers and markets. Now, that's not to say they won't talk about them and try to proclaim the fact that they're doing good in the world, but by and large, they're not going to put their best efforts, their greatest intellectual or economic resources into developing things for those markets because they will not see them as profitable or as really truly fulfilling their mission. Well, so what does that boil down to? Well, at least 10 million of the cancer patients in 2030 would be classified as non-consumers of diagnostic and therapeutic devices. Standards of care that are higher than none would potentially be acceptable for an innovative entrant to offer. Of course, this presents the innovator's ethical dilemma, which is how do I provide ethical care without doing damage? And of course, existing systems that are oriented around a return on investment are going to continue to ignore these patients and markets. So what else should we consider? Well, I've thought a lot about this, and my colleague, Dr. Afzal, has worked on this issue a fair bit. We need to ask whether or not this market is going to attract providers and services, and if so, under what circumstances. Will the existing high standard providers have difficulty endorsing good enough or better than nothing care? Yes, they will. And they should, because we should seek to provide the best we can for all we can. But of course, one of the challenges with this is that as we develop capable, competent people to provide that kind of care, they are inevitably attracted to higher resource settings where they can make greater economic returns. And then as we begin to bring these new innovations and personalized treatment options into there, who's going to do it? Who's going to have the innovation and the capability to do this? Well, let's look at this and think about this from a standpoint of what does the model look like. This is a model for healthcare in any of a variety of settings. And if we think about the developing world, why does it fail? Well, it may fail because of non-utilization, because of poor access due to distance or costs. It may fail because there's no supply chain. It may fail because people are poorly trained or because the best trained people leave and go elsewhere. It may fail because we render the wrong diagnosis and therefore get the bad outcome. It may fail because we don't have a sustainable economic system or the proper management skills and abilities to manage those resources and distribute them in a way that will serve the population. Well, we can't solve all of those problems today, not in 20 minutes, but digital pathology and artificial intelligence do have great potential to interact with this system and potentially significantly shift the number of people who achieve healthy outcomes relative to those who have adverse outcomes. And I believe this lies in two areas, one in training and second in quality of diagnosis and in capability of diagnosis. Now, one of the things we've witnessed in many areas is what I'm calling digital pathology hesitancy. These systems are often perceived as carrying a very high price with uncertain rate of return. And the costs and benefits of adoption are distributed very asymmetrically across the healthcare and social domains. So not everybody who invests in it is going to get all of their money back, and some of the people who didn't put a cent in are going to reap enormous gains. That is the asymmetry and the challenge. Now, public health trends, we oftentimes think they don't matter. You know, what's going on in Rwanda or Tanzania doesn't matter to what goes on in Salt Lake City or in Houston until they do. And then a virus that is hatched in Wuhan or someplace else spreads to impact the entire economic structure of the world. This pandemic has shown us that telehealth and telecommuting and other remote services can be provided and has presented an opportunity to learn from this experience in ways that may potentially help overcome this hesitancy and deliver care in ways that we haven't imagined prior, as well as education. So some of the gains that are to be had through digital pathology are truly efficiency gains. We can train more practitioners remotely. We can raise their quality of practice. We can increase the effectiveness of the specialists who practice in a niche area. We can increase access to their specialized care. And we can enhance access to clinical trials and advanced therapeutics due to the potential of digital pathology and covering these distances with these sort of technologies. One of the ideas that comes out of this is the potential for a residency in the cloud, if you will. And I know this is a lot of pipe dreaming on my part and several others, but it does become possible to begin to think about. What's needed? Well, access from anywhere at a low cost. Imagine a newly minted doctor who wants to train in pathology, but there's no program in his country. Well, he can gain access from that if he's got the appropriate mobile device, if he has the appropriate technology, he can look at that. We need standardized and, more importantly, curated content that can be appropriately delivered, that's directed and customizable for the needs of that individual in their location. We need some mentoring. This is not to be a void of personal interaction. And we need materials that will be helpful and effective in achieving competency that can then lead to a credentialable practice that will help and serve people. So as we think about this, what does Benji's future look like? Will AI and digital pathology bring to pass a bright future where people who develop malignancies in his country and culture have the opportunity and the access to appropriate diagnostic and therapeutic measures to assuage their challenges of cancer or other medical diseases that they will face? I think we have that potential. So what are we going to do? Well, one of the things that we have been engaging is to form an alliance of various stakeholders throughout pathology, across the domain, various organizations and individuals with interest to solve this problem. And that alliance is intended to tackle this problem and to begin to deal with the worldwide manpower shortage that AI and digital pathology can potentially help us to alleviate. We need some volunteers, we need organizational support, and we need leaders with passion who will innovatively seek solutions to help us to provide care for the millions of people who would otherwise not have them. You know, the old phrase, we have the technology. We have witnessed that through this pandemic, that we can deliver education, we can deliver diagnostics remotely in a very effective and efficient manner at a high quality level. So therefore the question is, will you provide the help? Will you provide the will? Can you provide the leadership and perseverance to deal with this challenge? We cannot expect to solve today's problems with the very systems that yesterday created them. Well, I thank you very much for your time and attention. Here is how to get in touch with me, and I would welcome your contact and interaction on these issues. If you have questions about the content, we certainly look forward to those. But more importantly, I hope that you'll join with me as a collaborator in confronting a very, very significant challenge in the decades ahead. And I thank you very much for your time, and I look forward to our question and answer period to come.